I wasn't sure if we were going to be able to get today's team ready in time. So I was really afraid you were just going to listen to whatever direction I went off on. So I made this just a little bit longer than our normal 12 to 15 minutes, which is okay today because we do have a little bit of extra time, which is my way of kind of apologizing up front that this is a little bit longer, but I think today it's going to be okay. If you have been on these ECHO learning communities for very long, you've probably sat through a couple of my dialogues or trainings or whatever you want to call them. From a very similar point of view, very similar topic, this is going to build on things that I've spoken about previously. If you haven't seen those, it doesn't make any difference. It's not like you had to have that previous knowledge for today's topic. But this really builds on what I talked about last time, which was just a few weeks ago, in thinking about some differential diagnostic understanding of adolescence and really framing things from that developmental perspective and the importance of staying focused on the developmental lens for understanding youth. That is, kids who would be between the onset of puberty, which is probably a couple of years before it really becomes visibly and behaviorally apparent, all the way through transition age. So adolescence is a little bit bigger period of life than I think we're used to considering. And the specialized individual, very individualized importance of that time of life, I think, is a lot of times overlooked, even by those of us who work with youth on a regular basis. So when you develop slides, they should be talking points, and they should not have this many words on an individual slide. But I wanted to pull two big things out of this document that's a couple of years old now, but no less relevant just because it's a couple of years old. This is from the National Academies of Science, Engineering, and Medicine, and I would strongly recommend this publication to anybody who works with adolescents, whether it's directly, indirectly, in family situations. This is the single best source that I've encountered that really addresses this stage of life from the specialized perspective of this stage of life, not talking about how adolescents are different from adults this way, or they're different from children this way. This talks very specifically, very directly about the purposeful nature of this time of life, and frames it from that perspective. So I found it to be the most useful single resource. You can create an account with the National Academies of Science, Engineering, and Medicine for free, and then you can download this for free. Or you can choose to pay $25 and have it shipped to you in paper. But downloading for free is always a great option. So, but pulling from the introduction to this publication, pointing out and then really guiding everything that's framed in this, the very specialized time of life that adolescence is, and all that's going on during that period of life, and reminding us that adolescents are not adults, which is something that's repeated in the few slides, actually the too many slides that I have developed for today. In really every time that I frame anything for adolescents, I'm reminding myself, in addition to others, that adolescents are not adults, even though many times they can have conversations that feel very adult. They certainly do things that look from the outside very adult, but they are absolutely not processing information in the same way that adults do, and not the same way that children do either. It is very much a specialized time of life. And so it emphasizes that and builds all the information from that. Points out that with all of the activity, and I mentioned a few weeks ago, that during adolescence, it is the second biggest period of brain development in our lives, second only to infancy. There's so much going on. There's all these connections being explored and practiced, and then eventually pruned away with that practice. But all of these extra connections, as areas in the midbrain really start to connect and process with the cortical areas, it means that adolescents have greater sensitivity to rewards. So what does that mean? Well, when you're thinking about drug and alcohol use, when you're thinking about peer interactions, when you're thinking about novel situation exploration, which is just a nice fancy way of saying doing risky things, they have a greater sensitivity to, that is they are drawn to all of these situations more easily. You know, if you think about pure behaviorism, if you're rewarded for doing something, if you're reinforced, actually a behaviorist would never say reward. If you're reinforced for doing something, what are you going to do? Well, you're going to do it again. So they have a greater sensitivity to that, and anything that can really tweak the reinforcement pathway has a much greater chance of being repeated. So when we're thinking about specifically the topic today, about thinking about how to consider drug and alcohol use for adolescents, drug and alcohol use represents a pretty big risk for adolescents, and that's an understatement way of saying it, partially because of this greater sensitivity to rewards. They remind us that adolescent brains are not simply advanced child brains or immature adult brains, something that I think that we need to repeat to ourselves and really to all of the collateral partners and the different systems that we work with that serve adolescents, that can use to be reminded that not advanced child, not immature adult brains. They are very much a purposeful period of life with a heightened sensitivity to reward and a greater willingness to take risks. The frame for just about everything that I consider with adolescence involves often a recognition of co-occurring needs. I'm going to talk about in a minute that I'm not a huge fan of the word disorder when it comes to working with adolescents. But co-occurring needs, co-occurring mental health, something, and co-occurring substance use, something. And from there it expands. And I think I talked about that a few weeks ago too. But just to define for our consideration moving forward, what is a co-occurring disorder? What is a co-occurring need? This is coming from SAMHSA. CSAT was under SAMHSA, or still is under SAMHSA. Defining a co-occurring disorder as when at least one disorder of each type, that is something from the mental health side, something from the substance use side, can be established or identified independently of the other side, and is not simply a cluster of symptoms resulting from a single disorder. So that is, we can identify that there is a mental health need or a mental health disorder. We can identify that there is a substance use need, maybe not disorder, but a substance use need. These things can be identified independently of each other. They exist independently of each other identification-wise. The truth is internally to any of us, nothing is completely independent. They're all interwoven, so they're mutually influencing. That's what this slide recognizes, is that mutual influence. We can recognize these needs independently of each other, but we can't really consider them independently of each other. If we break it down very, very simply and we say a kid is living with depression at some level and is experiencing some level of cannabis use, we can identify those things independently, but the cannabis use impacts and affects and influences the direction of the depressive feelings, and the depressive feelings then also have an influence in the other direction. So all of these areas are mutually influencing. We can't say that they're just completely independent. Also here, starting to recognize that I'm not a huge fan of saying disorder in adolescence. Certainly there are some areas that are so endemic to adolescence that yes, we can say disorder, and there's nothing wrong with saying disorder and mental illness. But in many cases, it's tough to understand things very specifically about adolescence, and there is great opportunity for moving in a healthier trajectory. So I prefer saying needs with adolescents. Certainly there are times when we can say, yes, this is depressive disorder. There's just no question about it. But especially on the substance use side, I am more of a supporter of saying needs rather than disorder, because there is so much opportunity for change during this active period of life, this active period of development of life. Also have, and I think I've mentioned this previously, moved away from saying really co-occurring disorders or co-occurring needs, specific to adolescents. As adults, it might settle down just a little bit. But with adolescents, as soon as you have something on the substance use side and something on the mental health side, that very quickly expands into influencing all of the dimensions and domains that kid exists in. If you think about that, the eco-contextual kind of stuff. There's a Brofenbrenner that, talked about the ecology of things. It's going to have an influence on family, and it's going to have influence on school and peers and interactions in the community. And all of these things, just like the mental health and the substance use being mutually influencing, all of these different contexts that the kid exists in has a mutually influencing interaction with the kid. That is, the kid influences that dimension, and that dimension influences the kid. So it becomes very complex. So as soon as we have identified that, there's a substance use need, there's a mental health need, very often it expands beyond that into multiply occurring needs, multiply occurring areas of this mutually influencing interactions. So all of this is building towards our target topic today, which is considering substance use identification / maybe a little bit of consideration of diagnosing for adolescents, but continuing to build the foundation for that. Just a quick inclusion and consideration of mental health needs. This is pretty old at this point, right? This is from 2005. You're probably familiar with this recognition that half of all lifetime experiences of mental health disorders, like crossing the threshold into diagnosability, so that it is having a negative impact on the person's functioning to that level. Half of all lifetime experiences of mental illness start by the age of 14. What that tells us is when we're working with adolescents, we are working with folks at the time when things really start to emerge in an identifiable, and then I think optimistically also in a healthier direction, amenable way, to say that in a way that's more complicated than it needs to be. But in a time of life when, if we can identify and match that kid with the right kind of support, it's very promising that these things are going to be far less impactful moving forward. It's not realistic to say that things are just going to go away, that we can cure everything, take it 180 degrees, but in a far less impactful way moving forward. And so if you were somebody who works with adolescents, this is a biased view, but I think that you're working at the time of life when you can have the single greatest impact. So this is also worth mentioning, thinking about identifying substance use needs in adolescents, because of the commonality of the overlap of mental health needs along with substance use. Typically speaking, mental health needs, symptoms, disorders, however you want to frame that, are going to precede the onset of substance use needs. Typically, that's going to come first. A little bit more in terms of the consideration of understanding what's going on with adolescents. I think that this is very telling. This is back from 2010. This is the National Comorbidity Study, the Adolescent Supplement. They randomly selected 10,000 youth. These were not kids that were referred through local mental health or CPS or anything like that. These were randomly selected youth. They were given an abbreviated version of several mental health assessments based on, this was DSM-4 at the time, criteria. Of the 10,000 youth randomly selected, just not with any kind of pre-identification, what percentage of those youth do you think cross the line into full-blown diagnosis? And if we were, live and we had a lot of time, then, we'd get a lot of feedback on that. It was 50%. Half of all randomly selected adolescents in the United States were found to have at least one diagnosable, not symptoms of, crossing the threshold into full diagnosis, mental health disorder. If you're raising an adolescent, that might be sarcastically believable, but are half of our adolescents to be diagnosed with a mental health disorder? And no, I mean, obviously not. And the folks doing the research came to the same conclusion. So they went back and they set a higher threshold. So it's not just checking the boxes for the criteria, but also have demonstrated impairment in their lives caused by this cluster of symptoms that have been identified that would otherwise be diagnosable. And when they set that bar, then they cut that number in half and they took it down to what we see in the adult population, which is 1 in 5, basically. 1 in 5 folks living at any given time with at least one mental health need, mental illness, however we want to frame it. So what this says is, if we use one of the potential things that this says, what it really says to me, focusing on adolescence, that if we use the adult-based criteria established from the DSM to understand adolescence, we run a significant risk of over-identifying, over-diagnosing, over-stigmatizing kids with disorders that they probably don't have. It's very difficult to understand adolescence from the framework that is provided for us in the DSM, and it takes a really specialized focus through the lens of understanding adolescence to be very careful and very purposeful about that. So that's what I take from that. That's the message in that. This slide will be in there. These will be sent to you. It shows the breakdown of where the different areas of need are. So moving to more on the substance use consideration side of things. If you're working with anybody in the state, whether it's a youth or an adult, and you've identified any kind of substance use needs in the treatment plan, then you're required to also conduct an ASAM assessment as part of the support for understanding of what the needs are, what the level of care is, and matching treatment to that. And coming from the ASAM, one of the assessment tools that we use, and one that I really like, and I think it's well matched to understanding adolescence. If you're familiar with it, it measures 6 different dimensions for areas of need and then risk, and then it also talks about the interactive complexity between those dimensions, or it has the possibility of doing that anyway. And it really tries to acknowledge that adolescents need different consideration and different match than adults. It has room to grow, but it does a nice job in that. But coming from that source, from the American Society of Addiction Medicine, their primary definition of addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Okay. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. How well does this really fit with adolescence? And we could have a long discussion about that, or you could get stuck listening to me in my soliloquy about that, and I'm not going to do that now, but just tuck that away, think about that a little bit. Does this really match with adolescence? Do we have to match adolescence to that? And as soon as we need to match adolescence to the definitions that we have, to the conceptualizations we have, and certainly the treatment protocols we have, then it's going backwards. That's not really individualizing things. And I think that this is something that we need to fit adolescence into rather than fits with adolescence, at least directly. Coming from the source that we're probably more familiar with, the DSM-5, It describes substance-related and addictive disorders as a pathological pattern of behaviors related to the use of substances. Don't know how well that fits with adolescence. A pathological pattern. What's going on during adolescence? They're changing their patterns. I mean, they're supposed to be. That's one of the main purposes of that period of life. Things look different. And how do we identify pathological patterns in folks who don't really have established patterns moving into adulthood? It's a difficult fit. Something else coming from this, an important characteristic of substance use disorder, underlying change in brain circuits. This is also a difficult fit because what's going on so actively during this period of life is a change in brain circuits. So these definitions they're obviously adult-based. They're adult concerned. They are not good direct fits in working with adolescents. And the piece that's circled there talks about individuals with lower levels of inhibitory control. Have you met an adolescent? They don't have lower levels of inhibitory control. They do as compared to adults, but it's not fair to compare them to adults. Their purpose, one of their many purposes, is that they are learning pathways for that inhibitory control. So understanding them diagnostically using this framework is very challenged. But with the brain circuit piece in mind, no pun intended, it really speaks to the importance of decreasing as much as possible, working with the individual, working with the kid, very importantly, working with the family, the caregivers, the systems, decreasing the amount of substances that they're using, decreasing the frequency of the substances they're using, because any kind of psychoactive substance at this time of life really impacts the direction of that brain circuit development. So thinking about the DSM, diagnostically, if you haven't looked at the DSM in a while, and really not familiar with the changes that were made in the 5, which are, I think, 7 years old at this point, it's no longer abuse or dependence. Now it's on a continuum, which is kind of a nice change. To get onto the list, to cross the threshold, you need to check at least 2 criteria out of a possible 11 to cross that threshold into at least the mild side of that continuum of a substance use disorder. They have organized the criteria by groupings. Criteria 1 through 4 involve examples of impaired control. Criteria 5 through 7 are examples of social impairments. 8 and 9 document risky use or kind of track risky use. 10 and 11 are what they call the pharmacological, or that's tolerance and withdrawal, is what they're comparing there. If you are familiar with the work of Kaminer and Winters, who do a lot of substance use work directly related to adolescence, a paper that they put out right after the release of the DSM-5, they said by organizing the DSM-5 around an adult concept of addiction, the public health value of and significance of early detection and referral to non-intensive treatment are greatly diminished. So what does this mean? Well, we can over-identify and really refer it to high of a level, or we can miss things because it's not a good match in understanding, using this adult protocol to understand where adolescents are. So just wrapping up, taking a look at some of these groupings and some of the considerations that I'm recommending that you keep in mind as you work with adolescents, both on both on the mental health and substance use, but that's oversimplifying things. But for the DSM, if we're thinking about that, from any of the chapters in understanding what's going on, is this something that was really normed on adults, and this is something that's significant to adults? How does this apply to adolescents? So in our 1 chapter of substance use, in the first grouping, the impaired control grouping, how do you measure impaired control instance for an adolescent? Because when we compare it to adults, which is not fair, but when we compare it to adults, they have impaired control, right? At some level already anyway. Adolescents are more opportunistic and binge users. If it's available, yes, and they're more willing to experiment, they will move towards novel situations, just as a part of where they are developmentally. So how does that really match with an impaired control criteria set. Criteria number 3, may spend a great deal of time obtaining the substance, using the substance, or recovering from its effects. It's probably not all that meaningful to most adolescents. Certainly there are cases when that is true. Most times, no. It's just infused into the normal social changes that are going on. And there are all of these changes, so things look different. Well, compared to when she was 10, yeah, she's spending a ton of time. Well, that's not a fair comparison. Because when they're in this period of life, it's really tough to say it's different now than it was before, because it's supposed to be different now than it was before. Criterion 4, this is one that was added in the DSM-5. They got rid of the have experienced legal trouble, which was good. They added craving, which was also good. But it really hasn't been validated or conceptualized how craving fits with adolescence. So it's something that we hear from adolescents that, yeah, I do have cravings for it, but just not a great match in understanding. The social impairment grouping. Things are changing socially for adolescents so much, and they're supposed to be. This is a really difficult area of match as well, because it seems like, oh yeah, things are changing. They're supposed to be changing. If you took the substance use out, would you still be saying that they're changing in those directions? So it's more difficult, it's more challenging to really identify those areas so that they're meaningful from the perspective of that kid. If we're not careful and we go through with these different areas of identification, these different criteria, we could check most of the boxes for an adolescent, and that would be an unfair over-identification of need. And as pointed out, you can take a look at these last ones if you want later. With the over-identification, are we over-stigmatizing youth by saying you have a full-blown substance use disorder, when it is more an example of, yes, they're moving towards risky stuff. We really do want to reduce your exposure to, your use of substances because of the risks that it represents. But is it truly to the level of a disorder? Is this more of a need? The stigmatizing piece can really turn kids off in terms of engaging in treatment. And it can also turn parents off or caregivers off in terms of, no, my kid isn't an addict, darn it. So is it more useful to be very conservative in our diagnostic approach and saying there's need here? We're not saying that we're going to cross the full threshold for diagnosis. So really, that's the message in general, not just with substance use, but then also with mental health needs. The rocket science statement of the day: adolescents aren't kids and they're not adults. So it can be easy to over-identify things when they are based on adult norms, because adolescents have so much variation into what they're doing. And just leaving you with an interesting hypothesis, this comes from, who's Harder and Harder? It says right there, in a book that was edited by Kaminer, who I referred to earlier, about substance use and co-occurring needs in adolescence. It's in the reference guide. I strongly recommend it. Where they promote the hypothesis that just about every need, it would be in a human being, but they're talking about adolescents, it can be traced back to suboptimal acquisition of psychological regulation during childhood. And I thought, boy, that really fits into the way that we conceptualize a lot of things in this ECHO, and how much can be accomplished in working with interoception that we talk about here a lot, and self-regulation skills for the youth and the parents that we're working with. So that was a pretty quick run through in those to get us done in time, which I'm almost in. I went a couple minutes longer than I'd hoped to, but